3 and 4 and 5 and 6 and 7 and 8 and 9 and 10 and 12, 13, 14, 15, 16, 17, 18, 19, 20, 22, 23, 24, 28, 29, 30. Done. And that's how we keep people alive.
Now let's just weekly patients.
So, we're starting out our video today about megacodes, and we're going to talk about the reversible causes today of pulseless cardiac arrest. So that's what the PCA stands for. So this is kind of half of what you would do in a megacode just for these algorithms. So just for the pulseless cardiac arrest algorithms. So that encompasses 4 rhythms. And we'll get to that in a minute. So let's talk about our reversible causes. All of these rhythms, all 4 rhythms, are caused by something that is potentially reversible, but then when it goes too far without being corrected, it's kind of hard to correct it at the very end, right? So but let's talk about our reversible causes, and they all start with an H or a T. So easy to remember. Now we have our vital sign causes, okay? Those have to do with our vital signs, okay? So one is hypoxia, so that has to do with our O2. All right, so the patient has been hypoxic for too long. One has to do with blood pressure, hypovolemia, so it could be caused by blood loss or some type of shock, right? And then our hypothermia, okay, so a really low body temperature. Now our laboratory causes have to do with mostly electrolytes, okay? So the one is hypokalemia. That will cause pulseless cardiac arrest. The other is hyperkalemia, okay? And then the other one has to do with the cause or the root cause of respiratory or metabolic acidosis. And that has to do with hydrogen ion excess, otherwise known as acidosis, okay? And then hypoglycemia is one of the causes. It used to be listed, hypo and hyper used to be listed as one of the H's and T's, but the recent update has clarified that, and hypoglycemia is for PEA, so pulseless electrical activity. It's for that specific rhythm only. So it's an H, a reversible cause for PEA. Okay, so now we have some more H's and T's. These are all the T's. So these were our H's under our labs and vital signs, and then these are our T's. So in a trauma, anytime you have direct trauma to a chest, you can have a few things happen as a result. So in the lungs, we have direct trauma to the chest. You have the risk of a tension pneumo, right? And then now we have an air leak, and it's pushing the rest of the chest over. So it can then push on the heart, and then stop the heart with that excess pressure pushing on the heart, okay? Then we have a cardiac tamponade. So direct trauma to the heart itself will cause and then the pericardial sac will then fill with blood. And then when it gets filled with too much blood, it will start to push on the heart, and the heart won't actually be able to beat until that blood is drained. So those are our 2 trauma causes of pulseless cardiac arrest. Now the medical causes have to do with toxins, which they could be anything, prescription, non-prescription, they could be plants, chemicals, alcohol, illicit drugs, the list goes on and on. Could be environmental exposures, work exposures, so those all kind of go under poison control, okay? So that's when you'd be consulting with poison control about what to do. All right, now we have thrombosis. So there are 3 types of thrombosis that are a clot, right, that will kill you, and 3 places that they go. So we have the one in the heart is a coronary thrombosis, otherwise known as a myocardial infarction. The other one, the one in the lung, is called a pulmonary embolism, right, or a PE. So that potentially, if it's large enough, it could cause pulseless cardiac arrest. And then we have a thrombosis in the brain, which is otherwise known as a CVA or a stroke. We need to talk about the basic steps of BLS. So every Megacode begins with, or a code blue, just begins with basic BLS. So what are those steps? All right, we talked about those a couple weeks ago, but let's get a little bit more in depth. So the first thing starts with an A, okay? So the first thing you do when you have seen someone go, or someone change and possibly go unresponsive, is you assess. So we assess the patient, okay? But we have to assess them. Remember my triple T, right? So we're gonna do a triple T and shout. Okay, so that's our tap, 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 shout, are you there? Whatever your phrase is. Okay, now once we figure out they're unresponsive, are they unresponsive? Yes, they are. Then we go to the next thing. We call a code, or we get help. So usually that code blue button is right above the head of the bed, so you can smack that button. If you're in the cafeteria or out in the parking lot and someone goes down, then obviously you're going to want to have someone call 911 for you, okay? All right, now, or if you're in the hospital in the cafeteria, you can have someone call the operator and then call the code blue overhead, right? Okay, either way we'll get you help. Now, our next steps after calling the code is, so now we've established that the patient is unresponsive, we have called for help, we need to check circulation, right? How do we check circulation? How do we monitor circulation? Well, we check a pulse. And we want to do a central pulse. And in adults, a central pulse is best felt at the carotid or at the femoral artery. So either our carotid artery or our femoral artery. Now, how long do we check a pulse? Well, we want to do it less than 10 seconds, but at least 5 seconds. So our pulse check is going to be at least 5 seconds, but less than 10. We don't want to spend time too long checking for a pulse because we gotta start pumping that heart, right? Okay, so now when there's no pulse, you start CPR. If there is a pulse, then you don't start CPR, obviously, and you do just respirations, right? And so that's where you get your ambu bag and you just breathe for them. Okay, so we assess triple T and shout. We called the code because they weren't responsive. We checked a pulse at the carotid or femoral, right? Now we're going to look at the airway after we start CPR, okay? Then we do our ratio, our 30 to 2, 30 compressions to 2 breaths, and then we're going to watch our airway, and we're going to watch for chest rise, okay? Now, the very next thing we need to do, and you can't delay, don't delay it for a complete set of compressions. Just as soon as you can, we want to defibrillate them. Either with the actual defibrillator, our Zoll, or if they have an AED, then we follow the prompts. Okay? Now, we want to make sure that so as soon as you've established that there's no pulse, you're going to start hooking them up to the defibrillator or the AED, okay? Now the AED, listen, it checks the heart rate, it checks the regularity, the rhythm, and it decides based on its algorithms built into it if it's shockable or not. The difference today between BLS and ACLS is this is where you stop. ACLS goes one step further. And now the AED goes away and there's no prompter telling you whether to shock or whether to continue CPR, shock not advised, right? So the AED will say shock advised, charging. And then when the light goes blinky, then you hit the button, right? And then you continue CPR. Well, when you do ACLS, that goes away and the only thing you're worried about is watching that rhythm. So you see the rhythm on the monitor, you decide if it's one of those 2 shockable rhythms, okay? And then we defibrillate. If it's shockable, you defibrillate. If not, you just keep on doing CPR. Okay, so I'm going to kneel down so that you guys can see this a little better. Okay, so now our good quality CPR, we want to pay attention to a rate. So CPR is really what keeps that heart going. We're not going to restart the heart, and it won't start beating from us just doing CPR, unlike what Hollywood will tell you. So, but CPR is really important because it is continuing to pump oxygen to all the vital organs and specifically the brain, okay, because we want to buy them time until we can defibrillate or give them medication, right? So we're going to do a rate of 100 to 120 beats a minute, and if you have a rate checker on your defibrillator or your AED, all the better, because it will tell you to go faster, and it will also tell you all kinds of other things. Go slower, go faster, right? Now, we also want to look at our ratio, and the ratio, this is before you place an advanced airway, okay? So we don't have them intubated, and we're just using a BVM or a bag valve mask to give them air. And so we want to keep our ratio to 30 C's to 2 B's, or 30 to 2. So for every 30 compressions, we do 2 breaths, then 30 compressions, then 2 breaths. Okay, now we have to worry about a depth. So how hard, how far down do we want to depress the chest? So we want to depress the chest at a depth of 1/3 the chest. Now, every group of people, so ACLS will divide it up into adult, child, and infant. So everyone, no matter their size, infant to adult, it's all 1/3 the depth of the chest. So in an adult, it's 2 inches. In kiddos, it's less than that. Okay, but if you just remember the 1/3, you'll be fine for all age groups. Okay? Now, we also want to do something really important after we push. So after we push down, we want to let go. Not necessarily let your hands off the chest completely, but you want to allow for, recoil. So we want to allow that heart to fill between compressions. That is paramount. That is so important, because if we're just pushing hard and fast, great. So that's pumping the blood out. But if we don't allow the heart to fill in between our compressions, we're effectively deleting their stroke volume, right? We can't, and they have no cardiac output. So we have to allow the chest to completely recoil so that the heart can potentially fill back up with blood, okay? So that's really important. Then we also want to worry about our compressors, the people that are doing all the hard work. If you've never done compressions, BLS, whatever, and on a real patient, they are pretty exhausting. And so you need to rotate, okay? So that means we change our compressors, right? We change our compressors every 2 minutes or 5 cycles of 30 to 2. So either 30 to 2 5 times or 2 minutes on the clock, whichever is the easiest. Okay, now we got to remember that during our ACLS, during our Megacode, we're going to need to be doing pulse checks, okay? That should be happening at the designated times, and we'll talk about that in a minute. But we want to keep our interruptions, pulse checks, whatever we're doing, putting in an advanced airway, we want to keep those down to a minimum, to our designated times or during our compressor changes. So you can change compressors during the breath part, right? So you're going to go 28, 29, 30, change while they're doing their 2 breaths, then the next compressor can come in and spell you out, because eventually, and it doesn't matter what kind of human you are, you will tire out. And guess what happens when you tire out? Who suffers from that? The patient does. And they won't do as well. And if you don't do good quality CPR, they have less of a chance of achieving what they call ROSC, or return of spontaneous circulation. So minimizing interruptions is key. Okay, now we're going to go to the next one. The question remains, to shock or not to shock, right? So CPR rule of wisdom. So if our end tidal CO2 goes down below 10, and if you remember, our normal CO2 should be between, depending on who you talk to, somewhere between 30, sometimes 35 to 45, somewhere in there, right? That's a normal person end tidal CO2. So if we really drop off, the reason why, anybody know the reason why? Has to do with CPR. The reason is CPR, your CPR quality sucks. So you got to change compressors or change what you're doing, because it's mostly because you've tired out. So don't be afraid to change up. All right, so our shockable rhythms, let's talk about these. So there are 2 shockable rhythms in the pulseless cardiac arrest algorithm. Now, those are ventricular tachycardia, or VTach, and this is pulseless VTach. There's also VTach with a pulse, and that is handled a little bit differently. We cardiovert those people. These guys, right, they do not have a pulse, because remember, this is pulseless cardiac arrest. So in VTach, what does VTach look like? Well, VTach has a QRS, right, and it also has a regular rate and rhythm. It's regular. It doesn't necessarily have a P wave or a T wave, but it has a regular QRS, okay? Now, the other shockable rhythm in the PCA or pulseless cardiac arrest algorithms is called ventricular fibrillation, right? Or vfib. So vfib, unlike VTach, has no recognizable QRS. It is not regular at all. It is a garbled, it's a rhythm and it's shockable, but there's nothing regular about it, okay? Now, and it can be either coarse or fine. Oh, there's all kinds of different things. So VTach usually looks like that. So VTach looks like that, where we've got regular QRSs, and then vfib is kind of, it's a rhythm, but it's not recognizable as a regular rhythm, and there's no QRS. Okay, so that's VTach and vfib. Now the non-shockable rhythms, okay? Have you ever watched on TV shows, on one particular TV show, where the patient goes flatline? Well, what is flatline known as? Flatline is known as asystole, right? Get rid of my funky S. Asystole, right? Agonal rhythm is another, it's an agonal rhythm, because there's not really anything there. It's mostly flatline, maybe with a couple few little blips here and there. Now, okay, so this does not get shocked. Well, why? That's because there's no electrical activity happening, and so in order for the defibrillation to actually work, you need to have electrical activity to shock, right? So if there's no electrical activity, you can't shock it, okay? And you also, okay, now, let's talk about the other one, is known as PEA, which is pulseless electrical activity, okay? So it is a recognizable rhythm. You're going to look up on the monitor, you're going to be like, whoa, hey guys, in the middle of the code, or at the beginning of the code, and you may be like, hey, look, it's sinus tach, or it's normal sinus. Ah, but what do you have to do with any rhythm when your patient's unresponsive? We got to check a pulse. The thing that distinguishes PEA from a normal rhythm, so PEA could look like normal sinus, it could look like sinus tach, it could look like, there's no what? You go to check a pulse, there is no pulse. So just because it looks like sinus on the monitor doesn't mean it's time to celebrate yet. Check a pulse. So we check for that pulse, and with PEA, it's no pulse, right? So then we continue to work through that algorithm for PE. We're going to talk about the drugs that we use in pulseless cardiac arrest. Now the first drug that we're going to use, and this is how they work. So we just use 2 drugs in the pulseless cardiac arrest algorithm. Easy peasy. So we use epinephrine, or epi, okay? Now, we'll talk about the dose in a minute, but let's discuss how it actually works. So it works, it's a positive inotrope, right? It drives up heart rate, so it increases our arterial blood pressure, okay? It also stimulates. How is it a positive inotrope? Well, because it stimulates our alpha and our beta. So it's an alpha and beta agonist, okay? It also increases our coronary perfusion pressure. It is also known as a very, very potent well, that's easy. If it's an alpha and beta agonist, if it's getting things going, then it's a vasoconstrictor. Okay? Increases the patient's chance of achieving ROSC. And that's kind of the end of the rainbow kind of thing. Almost the end of the rainbow in a megacode. So that is return of spontaneous circulation. So you're working the code, you're working them, and then you do a pulse check. You see a normal rhythm up on the monitor, you check a pulse, and you're like, yeah, it's got a pulse. So it's not PEA, it's an actual rhythm, right? Now, the second drug that we give is, in pulseless cardiac arrest, is amiodarone, okay? It acts on the AV node. So it decreases our AV node conduction rate, okay? It's an anti-arrhythmic, right? It is also known as another aspect of it is it prolongs QT. So that QT interval, it prolongs it out. So it's really good to help with an arrhythmia such as fib and our tach, okay? Epinephrine, okay? So epinephrine is given the first time, so we're going to go through timing. So the timing of epinephrine is given, right, in the tach vfib scenario, it's given post-second shock. All right, so once again, it's given post-second shock. All right, that is for our tach or vfib algorithm. Okay, now if we are asystole or PEA, the timing of epinephrine changes a little bit because we're not shocking. So we don't time it after the second shock, after the fourth shock, right? So we give it every 3 to 5 minutes because we're not shocking. So asystole and PEA, we time it every 3 to 5 minutes. For tach or vfib, we time it after the second shock. Then it's after the 4th shock, right? Then the 5th shock, after the 5th shock, we give the 2nd dose of amiodarone. So then after the 6th, and then 7th, and blah, 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 on and on until someone, calls the code or we achieve return of spontaneous circulation. Now let's talk about our dosing. The dosing is easy with epi. It's always the same, right? It's either 1 milligram or 1 amp. It comes in the syringe of 10 milliliters. So it's either the whole amp, which is 10 mLs, or 1 milligram, okay? Don't ever say the dose in milliliters because it could be a different concentration. So always give your dosing in amp, as in the vial that you're giving, the whole vial, or in milligrams, okay? It is always that. It never ever changes. So always, in pulseless cardiac arrest, it's always 1 milligram or 1 amp, okay? Let me fix my little monsters destroying my board. Okay, now, let's talk about amiodarone. So amiodarone It's a little bit different, right? It's only given twice, 2 times, and we only give it in which algorithms? So we only give it in the VTach, right? In our pulseless cardiac arrest, we only give it in VTach or vfib. So we give it post, right? We give it post third shock, because after the second shock, we give our first dose of epi. After the third shock, we give our first dose of amio. The first dose of amio is 300 milligrams, as we already talked about. It is IV push, just like epi. Not a drip, it's IV push as fast as you can get it in them. Now, it is also, right, because epi is post fourth shock, so then we give the second dose post fifth shock, all right? And the second dose is 150. So the first dose is 300, second time you half the dose to 150, an IV push. Now, after you give that second dose, no mo, there's no mo amio, okay? It's all gone. So we only give it twice, after the third shock, after the fifth shock. Now we're gonna learn how to put it all together. And this is with our drugs and with our compressions and our defibrillations. So how do we do the whole thing from start to finish? So we do our tap and shout, right? We call the code, check a pulse, start CPR if there's no pulse. So this now starts our pulseless cardiac arrest algorithm, okay? So we attach, while we're doing CPR, we attach our defibrillator in O2. We check a rhythm. Is it shockable? Well, we just learned about the shockable rhythms, right? So is it VTach and vfib? Okay, so we're going to do that algorithm first. You do the same basic things for VTach and vfib, and then PEA and asystole are different. So there's only 2 tracks to this. It's pretty simple once you get the feel of the pattern. So VTach and vfib, is it shockable? Yes, right? So we shock immediately, right? So you're starting CPR, you're putting your defibrillator on, we check, we see it's a VTach or vfib, so we do our first shock immediately, okay? Then we immediately, after the shock, we start CPR. Don't wait, don't check a pulse, don't do anything, just go and start CPR. So we're gonna start CPR, okay? And we do CPR for 2 minutes. So CPR is done for 2 minutes. After 2 minutes of CPR, or 5 cycles, then we do a rhythm. That's my little R. We do a rhythm check and a pulse check. Is it shockable? Yes. If it's still vfib and VTach, it is. So let's say, for the purpose of staying on this track and what we continue to do, if it's still VTach and vfib, then we shock them again. So now we shock them. And I forgot to say that we shock at 200 joules on a biphasic defibrillator. And most places have a biphasic now. That means that the electrical pulse or the electrical shock is coming from 2 directions. So whether you have the pad in the front or the back, or whether you have the pad up here in the upper chest on the right and down here in the lower left rib cage, it's all coming from 2 directions to surround the heart with a shock. So then we've done our second shock. So then we immediately what? We immediately start CPR. Okay? So we immediately start CPR, and as soon as we start CPR, we have our medication person give our first dose of epi. So we give our first dose of epi. Now, after 2 minutes of CPR, right? So 2 minutes or 5 cycles, we do another rhythm check to see, or pulse check, right? RNP pulse check, rhythm check. Then we see if it's shockable. Let's say it's VTach or vfib still. One or the other. If it's one of those, it's still shockable. So then we shock a 3rd time. It's always 200 joules when you're defibrillating. So we shock a 3rd time, okay? Then we continue CPR immediately after. Are you starting to see the pattern? So now we do CPR for how long? 2 minutes. And now we give our first. So we gave our first epi after our second shock. We give our first amiodarone after the 3rd shock. Okay? So we give our first amiodarone, and that dose is 300 milligrams. So our first dose of amiodarone given after the third shock is 300 milligrams. Okay, then immediately after that third shock, we're doing CPR for 2 minutes. We've given our amiodarone. That's all happening at the same time. Then after the 2 minutes of CPR, then we do another rhythm and pulse check, right? We see if it's shockable. It is. So we shock again at 200 joules. Then we do CPR immediately after, and we give our second dose of epinephrine. Okay, so our second dose of epinephrine, 2 minutes of CPR, right? Then we do another rhythm check. Okay, we do another rhythm and pulse check. And we see if it's shockable, okay? Then, yes, it is shockable. So we do shock at 200 joules, right? And we do CPR again. And now we give our second dose after our fifth shock, because this is our fifth shock. So now we're going to give our second dose of amiodarone. And that's at 150 milligrams. So the first dose of amiodarone is 300, second dose is 150. So kind of easy to remember, the first dose is more, second dose is half. Now let's pretend that, let's do the other side of the algorithms. So at any time, if this answer is no, when you do a rhythm check, and it's not shockable, you got to switch over to the non-shockable pathway, right? So our non-shockable is what? Well, we already learned that. That's PEA and asystole, okay? So PEA or asystole follows. So PEA or asystole, and that follows this track here on the right. So we, just like before, we did our tap and shout. We check a pulse, we call a code. They don't have a pulse, we check. We attach O2, we attach our defibrillator, we check to see if it's shockable. We look at the rhythm. Let's say for learning purposes that it is not shockable. So it's either PEA or asystole, right? So now what do we do? So it's not, right? So it's either asystole or PEA. Oh, here we go. Asystole, PEA, okay? So then what do? Well, we can't shock it, so we just continue our good quality CPR, right? And we do that for 2 minutes, just like before, just like over here, 2 minutes of CPR, right? Okay? Then during the 2 minutes, and at some point during the cycle, we need to start the clock. And the clock starts when the code starts. And so we need to give our first dose of epi, and that happens, we give epi every 3 to 5 minutes during the PEA or asystole algorithm. So just to shorten this up, for PEA and asystole, it's super easy. You don't shock, you just do CPR and you only give one drug, and that's epinephrine. So you just do CPR and epi, CPR and epi. Each time, every 2 minutes doing a rhythm check, making sure that it's not a shockable rhythm. If it's a shockable rhythm, then whoop, we move over here and we start shocking them. If it's not shockable, we just stay the course, keep on going, right? So now we do a rhythm and a pulse check every 2 minutes. See if it's shockable. Shockable, no, it's not shockable. So then we do CPR again for 2 minutes, right? And then we give more epi, 3 to 5 minutes. So CPR, we do a pulse check every 2 minutes. We give epi every 3 to 5 minutes. So it's a little bit different. So your recorder will be keeping track of that. So they'll be keeping track of the last time we did a pulse check, and they'll be keeping track of the last time we gave epi. So the shortest interval is 3 minutes for epi, longest is 5. And then forever we continue, right? Unless it becomes a shockable rhythm. If it moves over to the shockable side, then we work that side, okay? So now we consider, and this goes for both sides, while this is happening, we would be considering our H's and T's. Now remember, you're never going to be coding someone all by yourself, right? That's pretty low chances of doing that if you're in the hospital. If you're outside the hospital, anything goes. But if you're inside the hospital, there's going to be people that will help you. So a lot of what your providers are going to be doing are going to be thinking about their H's and T's, right? Our CPR, how often do we check CPR, or how often do we do a pulse check? We do a pulse check every 2 minutes, okay? And then that's when we decide, is it shockable, not shockable, okay? And so amiodarone is only given in VTAC and vfib, and it's alternated after every epinephrine. So you start out with epi after your second shock, then you do amio, then epi, then amio. Now, after the second dose of amio's done. He doesn't get any more. So we do 300, then we do 150. After the fifth shock, that's it. We don't do any more amio, and then after that, it's just epi shock, right? Of course, continuing with CPR. Okay, all right, so after we worked our Megacode, if at any time, it could happen anytime and surprise you, you might achieve what is called the end of the rainbow, right? So that is known as ROSC, return of spontaneous circulation. So we get a pulse back, and they have a normal sinus rhythm. Okay, so now it's happily ever after. Sweet, package them up, ship them out, great, we're done. Peace out. No, not quite, right? So we have to do a couple more things. So we have to find out if they're able to follow commands. So we know we have a heart rate back and they have a pulse, but we need to know if that person is still in there. We need to find out if they are still who they were before they coded, right? We need to see what kind of brain function we've got. So if yes, they're able to follow commands, now it's happily ever after. Not really, but you don't have to do the next bit. So let's talk about following commands. So basic commands that you should be asking them in this situation are, can you, these are some ideas, right? Can you squeeze my hand? Okay? Can you open your eyes? All right? So if they're able to do that, great. We don't go on to the next thing. However, if they are not able to follow commands at all, and that might look like this. The patient might be moaning, they might be moving around, like grabbing at things, trying to pull something off, not really conscious. So that's your answer. They're not able to follow your commands. All right? So now we initiate what is called, or we start what is called target temperature management. That's otherwise known as TTM. And that's where we try to maintain them, we cool them, and keep their body between 32 and 36 degrees centigrade, okay? We want to maintain them between 32 and 36 degrees centigrade, okay? And we keep that for 24 hours based on research, right? Evidence-based practice. Why? I always like to know the why. Maybe you don't, but you probably do, and that's why you're a nurse, right? Why? Why do we do target temperature management? Well, because it preserves, it's been found to preserve our noggin, or the technical term, right, is our brain or neuro. It preserves neurofunctioning to keep the body between 32 to 36 degrees, because if you think about it, you lower the metabolism, you lower their demand for oxygen. So now the demand on the body is much less, and we can preserve that brain function. How did we figure this out? I mean, it's just such a funny thing. Well, if you've seen some of those videos where how did I survive this, or I survived this, right? This was figured out through studying cold water drowning victims. So these cold water drowning victims, now obviously if they were below the optimal temperature, they didn't do as well, right? But these cold water drowning victims, after they would thaw them out or warm them up, they figured out that their brains and neurofunctioning were intact, okay? So their brains and their neurofunction was, oh my gosh, my grammar is horrid. Brain and neurofunction were, there we go, were intact. That's huge, right? So if we can keep them at this 32 to 36 degrees Celsius for 24 hours, we can give their brain the best chance of coming back online and restoring them to the person that they are. having that full brain functioning. Okay, now, when does this happen? So right after we achieve ROSC, we immediately stick them into cooling mode, right? So you can do that a few ways. You can do it with IV fluids, right? Through your fluid cooler that goes into the body, cools it as it's going in, or you can stick a cooling blanket on them. So that's your Bear Hugger brand or whatever brand you have at your hospital. And then you set the temperature to the fan that's controlling the blanket to 32 to 36 degrees Celsius. Or you might do both. Or if you don't have either, then we do cold packs and ice all around them. Try to monitor their temperature centrally, right, in their body. And a lot of times with these patients, they already have a Foley placed during the Megacode. And so a lot of your ICU Foley brands and the ones that the hospitals provide have that temp sensing Foley hookup. And so you can hook it directly to your monitor from the actual Foley catheter itself. So then you get a continuous central reading of your temperature in your patient. So that's really helpful because then as you're cooling them, you set it to say 33 degrees, set your warming or your cooling blanket or your cooling fluids to 33, and then you watch your patient based on the monitor, right? Okay, so we have several roles during a Megacode, okay? So first and foremost, we got my little helpful illustrator.
Hello.
She's gonna illustrate. Okay, so we have people doing airway. Go ahead, you can start drawing. So we got people doing airway. Then we got people doing the airway. All right, we got one doing the bag, operating the bag, and one person operating the mask. Just keep drawing like I'm not doing anything. Okay, then, so that's two people. So one doing the bag, so one squishing the bag, and one doing the mask, okay? Then we have somebody on the defibrillator, so one person doing the defibrillator, so that's charging and shocking, right? Then we have someone doing medication, so whether that's drawing up meds, pushing meds, and you can do one or two people doing this because it happens rather fast. So someone can be getting it ready, handing it to the medication person, giving it to them, then they can hook it up, then flush it, right? Then we have one person doing the recording, so they're the person keeping keeping track of when was the last time we shocked, how long it's been, and when was the last time we gave a drug, right? Because we got to time our drugs just right. Okay, so they're the ones keeping in charge of shocking when CPR was resumed, and what type of rhythm we have, and then when we resume CPR and shocking. Okay, now we have some person down here. Here, move over for just a second. And we got someone in charge. Okay, that person is the lead, and they're either the provider, but it could be a nurse as well, right? Until the provider arrives. Okay, now we have 2 to 3 people doing compressions. And this could be EMS, it could be nurses, it could be techs, paramedics, whatever, it could be hospital security. So whoever is BLS certified, as long as they're BLS certified, they can rotate in and do compressions. Okay, and that's the end of the video, and thank you, Little Miss, for doing our illustration.